We'll move on to the second round of debate. So for the proposition, the floor is yours.
All right, okay. So I'm Min Lee. So I would just like to bring us back to the definition of local therapy having no role in oligometastatic prostate cancer. So as mentioned, we refer to local therapy as both radiation therapy and prostatectomy. And we appreciate what our colleagues have mentioned about the potential role of radiation therapy in terms of symptom control. However, theory and what has been theorized to be helpful will ultimately only be a secondary concern, in that it is still most important we look at the evidence base that has been generated so far. And if we look at what we have on hand, okay. Okay, so if we look at what we have on hand, we acknowledge that the PEACE-1 trial does demonstrate that there is some improvement, or there is improvement in terms of time to the development of serious GU events. And this was a trial looking at patients with de novo metastatic prostate adeno-CA, a trial involving 1,172 patients. But if we look at the evidence base on the other side of the picture, we also see that in STAMPEDE, which was a far larger trial with 2,000 patients, there was no evidence of any difference in terms of their global QOL scores. And this was a pre-specified secondary outcome that the trial looked at, which we would argue is more relevant in this setting. And as our colleague also acknowledged, the HORET study also demonstrated that there is no clear evidence in terms of improvement, in terms of improvement to overall survival. Okay, in the overall population. Okay, so so this brings me to the next point, which is that which is that there are also very limited studies looking at the role of radical prostatectomy, and most of these studies that have been conducted have all been retrospective in nature. There were some potential findings in terms of PFS or CSS, but no clearly defined OS role in the studies that have been performed so far. So as far as we are concerned, local therapy, in the sense of including both radiation therapy and prostatectomy, has no clear role in oligometastatic prostate cancer at this point in time. We do not disagree that the evidence base may change in future as trials continue to mature. But okay, never mind.
Yeah, very good, very good. Big clap.
Hello. Okay, so I'd just like to, thank you to our, let me just talk about some points. Well, basically we have divided it now into radiotherapy and then radical prostatectomy. I think the evidence for radiotherapy, HORET was a trial which was negative, but it is true. But if you look at the stopgap meta-analysis that combined both HORET and STAMPEDE, they actually did show that there was overall survival benefit. Of course, one may argue that meta-analysis is just manipulation of data, but if you look at the trials themselves, even amongst HORET, those with a low metastatic burden disease, actually there was the trend did point towards some benefit. And in that sense, you could say that even despite the fact that HORET was just bone scintigraphy, meaning that you may potentially have a lot of patients which you have classified as oligometastatic, which are actually not oligometastatic in this day and age. If they were actually, they went through a PSMA PET, you might have a lot your population would be a bit more selective, and in those patients you could potentially see an even better outcome, which might then push it, beyond the confidence interval into a statistically significant region. This is the same for STAMPEDE, where improvement was observed in patients with a low metastatic burden, and there was some 3-year benefit in the overall survival, which improved by about 8%. And this was when you join it up together in the stopgap, then you see that there was a overall survival benefit. In terms of cytoreductive prostatectomy, yes, thank you for pointing out that there's good retrospective data from large studies from a SEER database, NCD, and the Munich Cancer Registry that does show that there's some benefit. I think more people, if you look, say that these are retrospective studies, then for some of the RCTs, things like trombone, which looked at feasibility of radical prostatectomy in these patients, they did show that the QOL scores are high and comparable between the standard of care as well as the intervention groups, and there was no difference in the EQ5D scores. If you look at some of these trials, as the trombone study as well, or the LOMP trial, you do find that there's a benefit in terms of local symptom control. For example, there's a reduced rate of bladder outlet obstruction events. Most complications from cytoreductive prostatectomy in the LOMP trial were grade 1 with a complete resolution, and most of the patients remain continent with comparable continence rates to patients who would otherwise have had observation or standard of care intervention. I think based on this evidence, if you look at both cytoreductive prostatectomy and RT, you can say that there is a role for both local control as well as possibly progression-free survival and overall, possibly even overall survival benefit. I also want to bring out the point that if you talk about SRMA, the one that was given to us in terms of, that was written by Mao, looking at cytoreductive prostatectomy, there are some, I will question the validity of that paper in terms of their use of the I-square statistic, which has been proved by von Hippel in 2015 to be a very imprecise and unreliable estimate of heterogeneity, and whether or not you should use a fixed or random effects model in that case is questionable, given that it's a small number of papers with significant heterogeneity.
Right, so we have 1 minute for you all to consolidate your thoughts before the concluding statement. Maybe at this juncture, I always remember what Prof. Edmund was telling me when I was a final year resident studying for my exit. He always say, don't miss the forest for the trees. So what's important in metastatic prostate cancer is a systemic disease. It's the ADT and your novel hormonal agents. How much time does novel hormonal agents buy in terms of the progression-free survival, the overall survival, and how much time does RT buy in terms of the STAMPEDE data? So I think these are some thoughts that you can have while you're designing your concluding statement. Anyone else has any